Good evening, one and all. Myself is Dr. Shivanagendra, and I am currently working as an assistant professor in the Department of Cardiology, UNMICRC Institute of Cardiology and Research Center, Ahmedabad. Today, we are discussing about regarding latest guidelines for infective endocarditis. Actually, this is not the latest. This is the 2023 ESC guidelines, which was published in 2023. Coming to the outline of today's topic, we are starting with introduction, and the second one is prophylaxis of infective endocarditis and the diagnosis of infective endocarditis and diagnostic criteria, and what are the changes in recent guidelines with regarding to imaging techniques, and what about antimicrobial therapy, what are the complications of IE and how to manage that complications, and indications for surgery in IE, and there are some specific situations. So coming to introduction, so infective endocarditis, we all know that infective endocarditis is an inflammatory process that affects the inner layer of the heart, either by infective or non-infective origin, which was first discovered by Lazare Riverier in 1646, and the term vegetation was first coined by Jean-Nicolas Corvisart. So to describe the mitral valve infective endocarditis, William Osler and Emmanuel Liebman. These are the two gentlemen which brought the disease into focus, and the patients are presented with fever. We all know that the timeline started from way back in 1646 to present 2024 and 25 recently. So these are the major events in the history of infective endocarditis. We already discussed regarding this. So coming to the epidemiology, so recently there have been substantial changes in the epidemiology of infective endocarditis in India. Particularly, IE is increasingly becoming common in older age group, more than 40 years, with no previously known valve disease as compared to younger patients with a mean age of around 24 years with underlying valvular heart disease. This is comparable to data which was reported by developed countries. In 2019, the estimated incidence of infective endocarditis was 13.8 cases per 1 lakh population, and which was accounted for 66,300 deaths worldwide. This was the data which I quoted from 2023 ESC guidelines, and due to associated with high morbidity and mortality, which is around disability adjusted life year is around 1723 and 0.87 death per 1 lakh population respectively. So these are the data which regarding to India, from particularly the studies was conducted by so many people, Soman et al. In 2018, Dr. Gupta in 2015, and the Subramaniam et al. In 2010. So these are the most common etiology which was found in India. So most of the, as we know that most of the cases it's a streptococci only, and the second to streptococci it's enterococci, and all the other remaining contributes to minor percent of the infective endocarditis. So the silent features of recent ESC recommendations, why we need this? The silent features were they boosted the role in imaging in the diagnosis, particularly, sorry for the mistake, it was PET-CT and SPECT-CT. And the second one is endocarditis team. And third one is the new recommendations for infective endocarditis in ICU and infective endocarditis with cancer and marantic, that is non-bacterial infective endocarditis. And recommendations for combination of early diagnosis and early antibiotic therapy and early surgery. And indications and optimal timing of surgery was highlighted. They mainly focus on prevention rather than prophylaxis to reduce the incidence of IE, particularly in the field of nosocomial endocarditis. There is no role of IE prophylaxis in this scenario. So coming to the antibiotic prophylaxis, what are the recent restrictions? So we generally discuss, there is a common scenario from bacteremia which coming from daily activities versus regarding procedures. There is a transient bacteremia. Whenever you are like toothbrushing and chewing, all these things will cause there is a transient bacteremia in the bloodstream. But that doesn't gives you infective endocarditis. This is the highlight of this point. This suggests that daily hygiene is more frequent cause of, this gives you infective endocarditis. This suggests that daily hygiene is a more frequent cause of IE than occasional procedures. So most of the case control studies did not report an association between invasive dental procedures and occurrence of IE. So for that matter, avoid one case of IE per 1,50,000 dental procedures, and one case of IE for 46,000 procedures which were unprotected by antibiotics. So coming to the antibiotic prophylaxis, these are the recommendations which was published in 2023 ESC guidelines. the recommendations was, as we already know that the antibiotic prophylaxis should be considered in patients with a high risk for IE. Who are the patients? The patients with any prosthetic valve, including a transcatheter valve, those whom any prosthetic material valve used for the cardiac valve repair. And the second set of patients were patients with previous episode of infective endocarditis. And the third set was patients with congenital heart disease. Particularly any type of cyanotic heart disease or any type of CHB repaired with prosthetic material, whether placed surgically or by percutaneous techniques, up to 6 months of the post-procedure. After that, the endothelialization will happen, or lifelong if residual shunt or valvular regurgitation remains. And antibiotic prophylaxis is not at all recommended in other forms of either valvular or congenital heart disease. These are the general prevention measures which was highlighted in recent guidelines for high risk and intermediate risk infective endocarditis. We know that brushing twice and professional dental cleaning follow-up at least twice yearly for high risk patient particularly, and strict cutaneous hygiene including optimized treatment for chronic skin conditions and disinfection of wounds, curative antibiotics for any focus of bacterial infection, no self-medication with any antibiotics, and antibiotic and strict infection control measures for any at-risk procedures, and discouragement of piercing and tattooing. There is a limitation of infusion catheters and invasive procedures whenever possible, and there is a strict adherence to care bundles for central and peripheral cannula should be performed. These are the updates about antibiotic prophylaxis in 2023. We already discussed about indications and what are the general preventive measures for antibiotic prophylaxis. Now these are the updates which highlighted the same thing. So general prevention measures has to be recommended as a class 1, and antibiotic prophylaxis is recommended in patients with ventricular assist device. So this is the next point which was highlighted in this slide. So for any left ventricular assist device or right ventricular assist device, there should be antibiotic prophylaxis before getting the procedures, and antibiotic prophylaxis may be considered in patients with heart transplant. That was a 2B. And the second thing was recommendations for infective endocarditis in prevention of cardiac disease. Optimal pre-procedural aseptic measures at the site of implantation during the CIED procedures to prevent the CIED infection. And we have to know that surgical standard aseptic measures has to be taken, and antibiotic prophylaxis for covering common skin flora like enterococcal species and Staphylococcus aureus should be considered before TAVI and other transcatheter valvular procedure. That is a 2A recommendation. And coming to the next slide, this is the common antibiotic prophylaxis which we will be given in every patient in high risk and intermediate risk patients. If there is the patient has no risk to allergy or ampicillin, no risk allergy to penicillin or ampicillin, you can give amoxicillin or ampicillin or ceftriaxone or ceftriaxone. If the patient is a known case of allergy to penicillin, or after that antibiotic sensitivity testing there may be allergy for penicillin, then we will go for cephalexin and azithromycin or clarithromycin, or we should go for doxycycline or cefazolin with ceftriaxone. And the antibiotic based on children and based on their weight, the antibiotic dose will be changed. That every dose of the antibiotic should be given 30 to 60 minutes before onset of the procedure. And we know that for any dental extractions and oral surgical procedures and procedures requiring manipulation of the gingival or periapical region of the tooth, that is a class 1 recommendation for giving antibiotic prophylaxis, which will before 30 to 60 minutes before the procedure. Systemic antibiotic prophylaxis may be considered for high-risk patients undergoing invasive diagnostic or therapeutic procedure of the respiratory, gastrointestinal, and genitourinary tract and skin and musculoskeletal systems. That was a class 2B indication. So the second concept which was highlighted in recent guidelines was the terminology called endocarditis-Cce, which was the first introduced in 2015 guidelines, and recently highlighted the what are the improvement in the endocarditis-Cce. Now coming to the what is the role of endocarditis-Cce, there are three main roles. So that one is, first one is the improved diagnosis and treatment. Second one is adaptability to clinical complexity, and the third one is enhanced clinical outcomes. So these are the role of endocarditis-Cce. So who will include in this team? The endocarditis team is mainly included. The core members are like cardiologists, cardiac imaging experts, and cardiovascular surgeons, and infectious disease ID specialists, along with microbiologists, along with outpatient parenteral antibiotic treatment specialist. So for these are some adjunctive specialties which can be useful for the diagnosis of infective endocarditis. This is the diagnostic criteria which was published in 2023 on the role of the endocarditis team. You start with empirical antibiotic treatment in any suspected case of infective endocarditis. After admission to heart valve center, so either adjust the antibiotic dose according to the blood culture results. So then go for endocarditis team. It's a multidisciplinary approach. If everything comes normal, so you like if blood culture comes positive, so then we'll go with culture according to antibiotic treatment according to culture. If culture becomes negative or any complications because of IE, so it will be managed subsequently. So coming to the diagnosis of infective endocarditis, that is a new major criteria which was published in 2023 Duke ISCVID infective endocarditis criteria. These are the major criteria. The highlighted bold letters which were mentioned in recent criteria was these are the highlighting points. The microorganisms that commonly cause IE isolated from 2 or more separate blood culture sets. That blood culture, previously there was a time frame, now the time frame was subsequently they reduced the time frame for routine common microorganisms, and microorganisms that occasional or rarely causes IE isolated from 3 or more separate blood culture sets. Previously there was a time limit within 2 to 3 hours, so there is a separate blood culture. Now the time limit was removed. And the positive laboratory tests, they include PCR and other nucleic acid based technique for Coxiella burnetii and Bartonella species, and particularly Trophima whipplei from blood. And Coxiella burnetii, we all know that the IgG titer should be more than 1:800, and isolated from a single blood culture is enough for the diagnosis of Coxiella. And they include indirect immunofluorescence assays for detection of IgM and IgG antibodies to Bartonella and Bartonella species, particularly Bartonella quintana and Bartonella hensley. And particularly coming to imaging techniques, imaging, previously we know that the echocardiography is the cornerstone for the imaging and the cornerstone for the diagnosis of infective endocarditis. And now they include the cardiac CT also, which is equally important as echocardiography. And any cardiac CT which is showing, other than echo confirmed, and cardiac CT diagnosis was showing vegetation or valvular or leaflet perforation with valvular or leaflet aneurysm, or any abscess or perivalvular abscess, any pseudoaneurysm or intracardiac fistula, or significant new valvular regurgitation on echocardiography as compared to previous imaging, or worsening or changing of pre-existing regurgitation is not a sufficient criteria. There must be new valvular regurgitation. Worsening or changing pre-existing lesion is not a sufficient. And new partial dehiscence of prosthetic wall compared to previous imaging. These were the imaging main criteria, and they include FDG PET as a main criteria and as a major criteria, one of the major criteria. Any abnormal activity which was involving the native or a prosthetic wall, prosthetic wall and ascending aortic graft with concomitant evidence of the valve involvement along with intracardiac device leads and other prosthetic material, which will be included in major criteria. And the third major criteria was surgical evidence. There is a surgical evidence documented by direct inspection during the heart surgery, neither major imaging criteria nor subsequent histological and microbiological confirmation. So any surgically removed vegetation should be sent to histopathological examination for confirmation of the diagnosis. These were the minor criteria. We all know that previously there is only predisposition character, and previous history of IE also included in minor criteria. Along with, we already know that prosthetic heart valve and previous valve repairs and congenital heart diseases and more than mild regurgitation or stenosis of any etiology, and endovascular CID, particularly CID diseases, and HCM and injection drug uses, and fever documented more than 38 degrees. We already know that vascular phenomena and microbiological phenomena. Particularly in vascular phenomena, they include cerebral and splenic abscess as one of the minor criteria. And positive culture for microbiological evidence, positive culture, PCR, nucleic acid based tests, all these included in minor criteria, which was not supposed to be major and included in minor. So the imaging criteria, any abnormal metabolic activity which was detected by FDG PET within 3 months of implantation of prosthetic valve or ascending aortic graft with concomitant evidence of valve involvement and intracardiac device leads or any prosthetic material. The main point was within 3 months. So that should be included in imaging criteria, which was included in minor criteria. Previously there were 5 minor criteria, now included as a imaging criteria also one of the minor criteria, and the physical examination criteria, which was new valvular regurgitation identified on auscultation if echocardiography was not available, or worsening, changing again I am telling you that worsening or changing the pre-existing murmur is not a sufficient criteria for diagnosis of infective endocarditis. These were the changes which was made in 2023 IS Dukes and ISCVID criteria. So we already discussed that pathological criteria, microorganism identification. So microorganisms identified by appropriate sample by PCR and amplicon or metagenomic sequencing and in situ hybridization were included as a major criteria. And we already know that typical pathogens, staph and enterococcus and streptococcus, except streptococcus pneumonia and pyogenes. And these are the typical organisms which was mentioned in recent criteria, and other microbiological tests also included in major criteria. And echocardiography, they included cardiac CT and FDG PET as a major criterion, and surgical diagnosis of histopathology as included as a major criterion. And we already discussed about minor criterion. Coming to the blood culture negative infective endocarditis, the definition of a blood culture negative infective endocarditis is infective endocarditis where the standard blood culture failed to identify the causative or microorganisms. It often results from prior antibiotic use and infections with fastidious or intracellular organisms like Coxiella burnetii and Bartonella or fungi. So the microbiological workup in stable patients is stopping antibiotics and repeating blood cultures may help. Particularly specialized cultures or serological tests or PCR assays targeting the specific pathogens is essential and guided by the clinical context and local epidemiology. And advanced molecular techniques like 16S and 18S rRNA sequencing and FISH techniques along with PCR, which has enhanced the diagnostic yield, and the non-infectious pathological should be considered. If all microbiological tests should be tests are negative, so you have to think about non-bacterial causes like autoimmune or neoplastic endocarditis should be considered, and testing for anti-nuclear antibodies and antiphospholipid syndrome markers are recommended. And the final thing was tissue analysis and diagnostic algorithm. Histopathological examination of the excised valve or embolic tissue remains the diagnostic gold standard, and a structured diagnostic algorithm include early microbiologist consultation, and along with subsequently you have to manage that case. This is the treatment of blood culture negative infective endocarditis. We already know that sometimes we encounter like fungal infective endocarditis also. For the brucella, you have to give doxycycline. Most of the atypical coverage you have to cover under doxycycline. And if Legionella, particularly the drug of choice will be levofloxacin. For mycoplasma, it is either fluoroquinolones or you can go with azithro. And if it is a Whipple's disease agent and tropilima whippeli, and it was by doxycycline is a drug of choice. And the treatment duration should be also varies from routine infective endocarditis for blood culture negative infective endocarditis. And particularly for fungal, you have to go with either echinocandins or amphotericin B for Candida, and voriconazole plus echinocandins or amphotericin B for Aspergillus. And long-term suppressive therapy with oral azoles is often necessary in fungal endocarditis. These are the echocardiography role in diagnosis. We already discussed all these. These are the guidelines. So you see that you have to just make the diagnosis if the TT is as a first line imaging. We already know that if any need for particularly suspicion of IE in prosthetic heart wall or repeating TE after 5 to 7 days is recommended in initially negative or inconclusive examination when the clinical suspicion of IE remains high. And particularly about prosthetic heart walls, so better to go with TE than TOE, because TE can sometimes obscure the image quality, and it was not a very good sensitive investigation for the identification of prosthetic wall endocarditis. This is for the diagnosis, and the second column is for follow-up and medical therapy. You have to repeat the echo on follow-ups. For any new complication of IE will be suspected like new murmur or embolism or persistent fever and bacteremia, or any heart failure or abscess or AV blocks. So in any cases of TOE, that is a transesophageal echo, is recommended when the patient is stable before switching from intravenous to oral antibiotic therapies. And during the follow-up of uncomplicated IE, repeat TT or TOE should be considered to detect silent complications. And the timing of repeat TE and TOE depends upon initial findings and type of microorganisms. If it is a high-risk organism, it is not a typical organism, you have to do early. And intra-operative and follow-up complication of therapy also, there is a follow-up TE is recommended. There is a role of, we already discussed the role of nuclear imaging. Now FDG PET is included, and the WPC SPECT is included as a major criteria in the diagnosis of infective endocarditis. So the one point was It was a very high sensitive, around 86%, but the specificity is also high, which is 84%. And WBC SPECT and CT is a very useful alternative, especially in detecting periprosthetic abscesses cases. In native involved endocarditis, these modalities have low sensitivity but high specificity. And in particularly about prosthetic quad valve, we already discussed the sensitivity is around 86 and 84 of specificity. And any detection of distant lesions and infection sources also it is very useful, like any septic emboli, any spondylodiscitis and septic arthritis, any are portals of the entry, there will be definitely uptake will be there. And the monitoring of treatment response, any patient you have to follow up and for a subject to any patient with confirmed IE who are not surgical candidates, which were managed on long-term long-term suppressive antibiotic therapy. So you have to repeat the FDG PET after 3 months or 6 months. This is the guidelines which already we discussed just now. So these were the guidelines which was cardiacs, particularly we already discussed about nuclear imaging. Now we will discuss about CT or MRI role. Cardiac CT is recommended. We already discussed cardiac CT as included as major criteria. So cardiac CT is recommended in all patients with possible native wall endocarditis to detect valvular lesions and confirm the diagnosis of IE. And FDG PET and cardiac CT are the recommended in possible cases of prosthetic wall endocarditis to detect the valvular lesions and confirm the diagnosis. So, and the brain imaging and whole body imaging like CT and MRI is recommended in symptomatic patients with native endocarditis to detect peripheral lesions or minor diagnostic criteria. WBC SPECT or CT should be considered in patient with high clinical suspicion of prosthetic wall endocarditis when echocardiography is usually negative or inconclusive, when FDG PET was unavailable. So, and so already we discussed regarding this, and this is the how we approach suspected cases of native wall endocarditis and prosthetic wall infective endocarditis. Any infective endocarditis, we have to assess the baseline assessment with blood cultures and major according to TT and TOE. That was a class 1 recommendation. After that, if it is a definite, you have to go for according to culture report, you have to go with antibiotics if it is a possible and rejected criteria. If it is a rejected, you have to suspect for alternate diagnosis or blood culture negative infective endocarditis. Coming to the phases of antibiotic treatment, recently we suggested that there are the phases of antibiotic treatment. The first phase is the early clinical phase, and the second one is the continuation phase with resting bacteria. And the first one, early critical phase is up to 2 weeks. In this case, you have to give inpatient treatment with IV bactericidal combinations along with if the needed are indicated, there will be a subject the patient to the surgery and the removal of infected cardiac devices plus draining of the any abscesses. And the second continuation phase with resting bacteria from day 10 onwards, you can perform TE before you therapy, which we already discussed. That was a class 1 indication from early critical phase to continuation phase. You have to do follow PICO. If any complications are be there, you have to continue IV antibiotics. Otherwise, if the patient is recovering, so you have to change him to oral antibiotic therapy. So this is the empirical treatment before pathogen identification. So we know that the recommendations are in guidelines for only 2A and 2B only. There is no class 1 recommendation for empirical treatment. The first first column depicts that there is community acquired native wall endocarditis or late prosthetic wall endocarditis, which was more than 12 months post surgery. You can go with either ampicillin or ceftriaxone with gentamicin. This is we already practicing this. And in early cases of prosthetic wall endocarditis, which was less than 12 months post surgery, or nosocomial infections or non-nosocomial healthcare associated infections, vancomycin or daptomycin is combined with gentamicin and rifampicin may be considered using following doses. And if the patient is allergic to beta-lactams, if it is a community acquired native wall and prosthetic wall more than 12 months, you have to go with cefazolin or vancomycin or gentamicin. These were the recent changes which was recently highlighted in 2023 guidelines, which was outpatient antibiotic treatment for infective endocarditis. Why these recommendations will recently populated? Because popular because of there is a now we briefly discuss about oral antibiotic therapy, how it will be helpful in infective endocarditis. The first one is we already discussed that from early critical phase to continuation phase, there must be follow PICO. After that, you have to transition. You have to give the transition from injectable to oral antibiotic therapy in transition criteria and phases. And if clinical stability assessment has to be there, the stability means in self using clinical signs, the patient is favorable for more than 2 days, and lab markers like CRP1 decreasing trend. A structured flowchart decisions should be made, and implementation and monitoring of oral antibiotic regimens with mirror acute phase antibiotics when possible, using once daily dosing or infusion pumps. Therapeutic options and alternatives like oral step-down therapy involves the specific two-drug combinations, which was involved in POET trial was amoxicillin and linezolid, and dalbavancin and long-acting glycopeptides. So dalbavancin, which is a long-acting glycopeptide, which may be used in gram-positive IE. For staphylococcal IE, the regimen of IV chlorotrimazole plus clindamycin followed by oral cotrimoxazole is a potent alternative, though evidence is limited. The trial which was recently highlighted in recent guidelines was the POET trial, which was based on IV antibiotic versus oral antibiotics. So that it was the follow-up around 10 years. And the trial uses most of the common pathogens like Staphylococcus and Enterococcus and Streptococci. The two antibiotics which were used in the trial was amoxicillin and linezolid. This is we already discussed that outpatient-based antibiotic should be considered in patients with left-sided IE caused by routine organisms like Streptococci, Enterococcus, and Staph aureus or cons, who were receiving appropriate IE antibiotic therapy for at least 10 days or at least 7 days after the cardiac surgery, and if patient were clinically stable and do not show any signs of abscess formation or valve abnormality requiring surgery on TE. These are the subsets. The class recommendation is 2A. And any outpatient parenteral antibiotic is not recommended in patients with IE caused by highly difficult to treat microorganisms and liver cirrhosis cases, severe cerebral CNS complications like cerebral emboli, and untreated large extracardiac abscesses, and heart valve complications and other severe conditions which was requiring surgery. These are the not a subset of patients for OP-based antibiotics. We already know that these are the surgical indications, and we will discuss regarding indications of surgery and management of main infective endocarditis complications. We already know that there is a three main indications for surgery. The first one is heart failure, which was uncontrolled heart failure, and second one is uncontrolled infection, and third one is a prevention of embolism. So we already know that there is a three criteria. Then first one is emergency surgery, and second one is urgent surgery, and third one is elective surgery. Emergency surgery is recommended in aortic or mitral native valve endocarditis or post-acute endocarditis with severe aortic regurgitation or obstruction or fistula causing refractory pulmonary edema or cardiogenic shock. This was the indication for emergency surgery. You have to perform surgery within hours. For the urgent surgery recommended in aortic and mitral native valve or post-acute endocarditis with severe AR and obstruction symptoms causing heart failure or echocardiac signs of poor hemodynamic tolerance. This was the class 1 indication for heart failure. We already know that uncontrolled infection is also one of the criteria. The prevention of embolism, if the vegetation size is more than or equal to 10 mm, particularly in left-sided IE, so that is a class 1 indication for doing surgery because there is a high risk of embolic risk will be there. Urgent surgery may be considered in aortic or mitral vegetation more than 10 equal to without severe valvular dysfunction or without clinical evidence of embolism has a low surgical risk as a 2B indication. Complications of infective endocarditis. So we will now see the complications of infective endocarditis. There is a neurological complications. So in any neurological complications, you have to perform the brain CT or MRI in patients with infective or suspected infective cerebral aneurysms, and neurosurgery or endovascular therapy is recommended for large aneurysms, those with continuous growth despite optimal antibiotic therapy, or ruptured intracranial aneurysms. If non-invasive techniques are negative, then the suspicion for infective endocarditis remains very high, so invasive angiography should be performed, but it is a class 2A indication. In any embolic stroke, the mechanical thrombectomy may be considered if the expertise is available in timely manner, and thrombolytic therapy is contraindicated in embolic stroke due to infective endocarditis. There is class 3 recommendation, which was generally we are not doing thrombolysis in cases of embolic stroke which was due to IE. So second one is timing of surgery after this was the common scenario which was encountered in our day-to-day practice. Once the patient after developing infective endocarditis with neurological complications, when surgery will be performed. This is the timing of surgery recommendations in recent guidelines. After a transient ischemic attack, the cardiac surgery, if indicated, is recommended without delay. After a stroke, Surgery is recommended without any delay in progress in presence of heart failure, uncontrolled infection or abscess or persistent high embolic risk. As long as coma is absent, you can do surgery. The presence of cerebral hemorrhage has been excluded by CT or MRI. This was a class 1 recommendation. You can go with surgery in transient ischemic attacks, and you can go with surgery which is not a hemorrhagic surgery, as long as patient is not in coma, and which was GCS was very good. The following intracranial hemorrhage, delaying cardiac surgery for more than or equal to 1 month if possible, with frequent reassessment of patient's clinical condition, and imaging should be considered in 2A. In patients with intracranial hemorrhage and unstable clinical status due to heart failure, uncontrolled infection, and persistent high embolic risk, urgent or emergency surgery should be considered, weighing on the likelihood of meaningful neurological outcome. So you have to frequently assess the neurological outcome. If intracranial hemorrhage will be there, you have to postpone if possible for more than 1 month. If it is not possible and the patient is very sick, you have to weigh the risk and benefit. If the benefit is high and GCS was muscle was very good and neurological status was very good, you have to go with surgery, which was a class 2A recommendation. And the second complication was splenic complications. Splenic complications including infarction of the splenic infarction, which was seen around in 20% of infective endocarditis cases, and the second one is splenic abscess. Sometimes it might rarely rupture, and it might be asymptomatic also in most of the cases. Or the patient may be presented with fever or abdominal pain or persistent bacteremia, and the imaging is essential for evaluation. The management strategies include antibiotics and surgical considerations for and prevention. Minimally invasive options like percutaneous drainage or laparoscopic splenectomy are alternatives in any high-risk patients. Post-splenectomy vaccination against encapsulated organism should be recommended. So for any surgery, before you have to go for surgery, you have to perform the splenectomy. Then you go for valve surgery to prevent the reinfection. So if you want to go for with splenectomy, first do splenectomy and then go with for valvular surgery. And the third complication is myocarditis and pericarditis. Acute myocarditis in infective endocarditis is very rare, and it is likely immune mediated. Presenting as an acute heart failure and ventricular arrhythmias. Diagnosis mainly relies on, we know that echocardiography is the commonest diagnostic modality. The pericarditis is also uncommon, often linked to ring abscess and extension into infective endocarditis, which was rupturing into pericardial space and gives to pericarditis. In reported cases of 19% in aortic, which was high in aortic, and 12% in mitral valve infective endocarditis. Pericardial effusion is seen only in 7.8% of the cases of native valve infective endocarditis cases, with increasing heart failure risk during hospitalization, but did not significantly impact on surgical rates or mortality. And the fourth complication was heart rhythm and conduction disturbances. Atrioventricular block in infective endocarditis result from paravalvular abscesses, particularly near the aortic valve, because we know that conduction system AV node is near to the aortic valve, and which is around NCC and RCC junction due to close anatomical relation between heart valve and conduction system. In uroendoregistry, the conduction abnormality was present in 11.5% of IE cases, with new onset AVB indicating need for urgent surgery. Without IE also, we know that post AVR or post TAVI, if the patient, even particularly for TAVI, any self-expanding walls or any depth of implantation is more, definitely there will be risk of AV blocks will be there. Particularly AV block post-valve surgery with 12.8% of the survivors requiring pacemaker, with risk factors include prolonged PR or QRS interval, Staphylococcus aureus infection, and aortic root abscess and tricuspid involvement, and prior valve surgery. Pacemaker implantation should be considered in any high-risk surgical patients. And the fifth complication was musculoskeletal manifestations. These are like three types of manifestations, which was articular and spondylodiscitis with tie link, and rheumatological manifestations. We already know that the Staphylococcus aureus is the most common organism which was involved in osteoarticular infections. And patients with pyogenic spondylodiscitis and positive bleaching should undergo TTE or TE to rule out IE. IE is 10 times more common in these patients. Spondylodiscitis does not worsen IE prognosis but delayed IE diagnosis. This point we have to remember that any patient with pyogenic spondylodiscitis, you have to perform him for 2D echo or any transesophageal echo to rule out IE, because it sometimes delays the diagnosis of infective endocarditis, which will result in poorer outcomes. Rheumatological malignancies like immune-mediated, these include myalgias and around 12 to 15% of the cases, and arthralgia around 10% of the cases, and sacroiliitis is less than 1%, and polymyalgia rheumatica-like symptoms is in 0.9%, and leukocytoclastic vasculitis in 3.6 cases. These will typically resolve with antibiotic therapy and do not affect the IE prognosis. The sixth most important complication of IE after the neurological complications was the renal failure. So acute renal failure is a frequent complication of IE affecting 18% of the patients and linked to increasing morbidity and mortality and healthcare burden. Severe cases requiring dialysis even in 6% of the cases and carries the 40% mortality risk. The contributing factor for acute renal failure are immunomediated glomerulonephritis and septic embolic infarctions and heart failure related hypoperfusion and nephrotoxic antibiotics like aminoglycosides and vancomycins, NSAIDs and high dose diuretics and contrast agents which were used in imaging. These are the contributing factors for acute renal failure in infective endocarditis. So how we will manage acute renal failure in infective endocarditis? The nephrotoxic agent should be minimized or closely monitored with regular assessment of drug levels and renal functions. In patients with impaired renal function, non-nephrotoxic imaging alternatives like contrast enhanced ultrasound or MRI should be performed. Coming to the surgical therapy, what are the principal methods? This is a pre-surgical workup in which patients of infective endocarditis, the coronary angiography should be performed. In hemodynamically stable with aortic wall vegetation, who require surgery and with high risk for CAD, so there should not be performed coronary angiography because there is a manipulation of catheter, there is a high risk of there is a cardiomyopathic stroke. So in these kind of cases of aortic infective endocarditis, whether it is a native or prosthetic wall, you have to subject him cardiac CT, coronary angiogram. And the invasive coronary angiography should be performed in patients who are requiring cardiac surgery who are high risk for CAD in the absence of aortic wall vegetations. In emergency situations, without preoperative coronary assessment, regardless of CAD should be considered, and invasive angiography should be considered despite the presence of aortic vegetations in selected patients with known CAD or high risk with significant obstructive disease, which was a class 2B indication. So better not go with CAG in aortic infective endocarditis. If you want to go, so then will be high risk of stroke and bleeding risk. Answer will be there. And the second thing is a choice of the valve. So the choice of valve is mainly based on general patient characteristics and IE specific considerations regarding stroke and bleeding risk and surgical complexity. These are the factors favoring non-mechanical valve substitute in the setting of surgery for acute infective endocarditis. So when you should use bioprosthetic heart valves like early surgery in recent ischemic stroke because there is a high chance there is a contraindication for anticoagulation like these cases, and evidence of intracranial bleeding, and women of childbearing age, the high likelihood of prolonged mechanical circulatory support, advanced age and frailty, poor or unknown medical complaints, and if the patient preference is go with either bioprosthetic valve, you have to go with bioprosthetic valve. Coming to the recurrences and relapses and reinfections, factors associated with increased rate of relapse after infective endocarditis were inadequate antibiotic treatment and resistant microorganisms, and infective endocarditis caused by Staph aureus and Enterococcus species, polymicrobial infections who will inject drugs, and periannular extensions, prosthetic valve endocarditis which were missed, and persistent metabolic foci of infection like abscesses, and resistant to conventional antibiotics, and a positive valve culture, persistent of fever at the 7th post-operative day, and the chronic kidney disease, especially on dialysis, and high risk behavior and inability to adhere design and poor oral hygiene. Any storage of isolates following infective endocarditis episode, if any available storage for isolates are there, you have to subject him for tissue diagnosis. If the same species is isolated, if it is the same species was identified from the same previous stored isolate, which is called relapse. So if it is not identified, it is called reinfection. Prosthetic valve endocarditis, particularly we will go with last topic, which was specific situations. Prosthetic valve endocarditis, why it is different from native endocarditis, which is the most severe form of infective endocarditis, accounting for 20 to 30% of the cases with increasing incidence over time. It is more common in bioprosthetic valves, and can be classified as early onset prosthetic valve endocarditis or late onset. We already discussed less than 12 and more than 12 is a late prosthetic endocarditis with differing in microbiological profile. Staph aureus and nosocomial pathogens dominate early PVE, and the streptococci and cons are more common in late PVE. The diagnostic challenges, we already know that that's why TOE is recommended in diagnosis of prostate endocarditis. Because of atypical presentations and low sensitivity of echocardiography and blood cultures, TE is essential, and advanced imaging techniques like FDG PET and CT will improve the most diagnostic acts. Always put low threshold for doing transesophageal echoes and FDG PET in any suspected case of prostate and infective endocarditis which was not responsive to your regular and routine antibiotics. And the prognosis and management is prostate endocarditis has high hospital mortality around 20 to 40% and worse long-term clinical outcomes than native wall endocarditis. Surgery is often necessary, and particularly high-risk cases of heart failure, abscess and persistent fever, we have to go with the surgery. Particularly, we will go with IE with the elderly patients. So, IE in elderly is increasingly common after associated with enterococcus and staph aureus. Recently, we know that in a CIED and TAVI recently performed in like old age people and healthcare related infections, this group shows a lower risk of embolic events compared to younger age group. And surgical hesitancy and outcome will be one of the main contributing factor. And we have to, if the age is obviously more than or equal to 80, study shows that there will be similar surgical mortality whether you perform surgery at less than 80 and more than 80, unless another the patient is indicated the surgery was not indicated based on age and comorbidities and prior procedures. And you have to assess for functional nutrition status, which was the predictors to outcome. So, coming to the topic of infective endocarditis after transcatheter aortic wall interventions. So, IE incidence in post-TAVI is around 0.3 to 1.9% for 100 patient years, similar to surgical AVR only, with highest risk in the first 3 months. So, risk factors include younger age, male sex, and renal dysfunction, and residual aortic regurgitation. IE rates are consistent across all wall types. One study reported lower PV incidence post-TAVI than surgical walls. Diagnosis is challenging due to atypical presentations and metal stent frames. Fever may be absent in 13 to 20% of the cases. TOE often misses the vegetation, 38 to 60% of the cases. The TOE transesophageal echo obviously sometimes misses the vegetations, and vegetation may be in stent frame in 12 to 19% of the patients. And outside the wall, particularly in other wall like mitral wall, in other 12% of the cases. So advanced imaging like FDG PET and CT or intracardiac echo improve the diagnostic accuracy and alternating the diagnosis. The prognosis is high complication rate and mortal rate will be around 16 to 36 in hospital and around 59% at 1 year. Staph aureus has a worse prognosis, and surgery is rarely performed due to age, comorbidities and technical challenges, because we already know that post-surgical, post-TAVR wall removal was a little bit difficult, and benefit is unclear except in cases of abscess or fistula. Wall-in-wall TAVI may be considered after healed IE or a negative TOE, ideally delayed after 1 to 3 months. Coming to the endocarditis following transcatheter pulmonary wall interventions, the incidence and risk factors are like 1 to 6 to 4% of the cases of 100 patient year, higher than surgical pulmonary wall procedures. Risk factors include younger age, we already discussed prior IE and high residual transvalvular gradient, and wall type is bow and jugular vein walls, which was like Cantagra, like bow and jugular walls may influence the risk, and through multi-center data which shows no difference. And diagnosis is difficult. Intracardiac echo and FDG PET are valuable when TTE and TOEs are negative. And staph aureus and oral streptococci are most common organisms. And prostate wall stenosis is also common, which was 33 to 50% of these conductive stenosis will be there, and surgical replacement rates were range from 26 to 56% of the cases. Valve-in-wall TPVA or balloon dilatation may be used in post-healed IE or urgently for stenosis. Mortality is lower compared to TAVI-related IE and reflecting younger and healthier TPVA cohort. These are like TPVA patients are more younger than TAVI patients, so that's why. So obviously mortality will be lower. So definition, coming to the infective endocarditis affecting CIED, implantable devices, and the CIED definition, infections were classified as a localized, that is superficial pocket infections or systemic with or without visible vegetation. The CIED related infective endocarditis involves clinical signs of pocket infection or imaging evidence, that is lesion vegetation or FDG uptake. Infections typically arise from skin flora introduced during implantation or hematogenous seeding is less common. Microbiology and risk factor, staph aureus and cons are the most common pathogens. Others include enterococcus and Cutibacterium acne and rare gram-negative or fungal organisms. Risk factors include procedure-related, that is immunosuppression, or procedure-related re-interventions, and device-related. You already know that there is a PADIT score which will stratify the infection risk. The include previous procedures and age and depressed renal function. The PADIT score include the previous interventions, age and depressed renal function, immunocompromised status, and type of the implant. So based on that PADIT score, you can assess the high risk versus low risk versus intermediate risk of infective endocarditis following the CID implantation. And prevention and diagnosis, prophylactic antibiotics like cefazolin or vancomycin within 1 hour of incision are standard, and post-op antibiotics are generally, there is no trial which will show the benefit of post-op antibiotics. Antibiotic medicine will have reduced the risk of infection in particularly high-risk cases, like example, repeated CRT revisions as shown in rapid trial. Diagnosis relies on clinical signs, blood cultures, and imaging. Staph aureus bacteria may strongly suggest to TAD infection, especially without other infection sources. These are the imaging modality. TE and TOE is the first line. Intracardiac imaging also useful when TOE is not feasible. Vegetations can be often missed. Advancing modality like FDG PET or WBC SPECT should be considered in any systemic or pulmonary complications. Caution should be taken whenever fibrinous lead masses in asymptomatic patients, which was not a predictive of IE. So you have to cross-check that you are not misleading because of fibrinous lead masses. So the treatment and extension, initial management will be proper and complete device removal plus empirical antibiotic targeting MRSA and gram-negative organisms, and you have to extract that whole device, and it should be performed early within days, and preferably percutaneously in expert center, and surgical extraction is reserved for large vegetation more than 20 mm or concurrent wall surgery. The special considerations are extraction is advised even without the vegetations in persistent gram-positive or fungal bacteremia. Sonication of extracted hardware improves the microbiological yield. The reimplantation strategy, you have to reimplant after more than or equal to 72 hours of negative blood culture or more than 2 weeks if vegetations were present. Site and device choice will be, obviously it has to be new site, never use the old components, and consider leadless pacemaker if recurrent infections will be there, and subcutaneous ICD in high-risk patients. There are some bridging options, and generally we are not performed those bridging options. If we need and wearable ICDs, and epicardial pacing is an alternative for high intervention risk. These are the recommendations for a CID infective endocarditis. We already discussed all this. And removal of CID after single positive blood culture with no other clinical evidence of infection is not at all recommended. Any single positive blood culture, so always treated with conservatively. You have to go with antibiotic. If it is an IE, or we previously discussed what are the possible risk factors in CID. So in these kinds of cases, only you have to perform extraction. Otherwise, with single positive blood culture, you have to treat it medical. IE in ICU cases, ICU in IE is common due to complications like septic shock and acute heart failure and multi-organ failure, especially in older comorbid patient. Healthcare associated IE is also more. Increase in hospital mortality ranges from 32 to 42%. Poor prognostic factors include older age, high SAP score and SOFA scores, and MRSA infection, native wall infected endocarditis, and while cardiac surgery, Bale sex and Streptococcus faecis are linked to better outcomes. Right side IE, although less common, which is less than 10%, carries high risk mortality in ICU settings, particularly in patients with injectable drugs. And Staphylococcus aureus is the most frequent and lethal pathogen, which is up to 56% of the cases, and others include Streptococcus and gram-negative bacilli in Canada. Concerning negative cases, serology and PCR should be performed to identify the pathogen. A diagnostic challenging in a typical presentation like delirium and misleading fever patterns, TOE should be essential to detect the complications, and the management you have to manage accordingly. Right-sided IE accounts for 5 to 10% of the cases, rising incidence due to increasing risk factors like congenital heart disease, CIDs, and indwelling catheters, immunosuppression, especially for people who inject drugs. Staph aureus is the predominant organism. And you have to go, diagnosis can be easily made by TE, which is good for tricuspid valve, and TE especially pulmonary valve and CIDs. Clinical presentation include fever, bacteremia, and typical like pulmonary symptoms and septic emboli. Occasionally right heart failure due to regurgitation of septic emboli. The management include you have to do subject have to blood cultures. According to that, you have to manage. Prognosis worse in a CID related immunocompromised patient. especially with fungal infections. Empirical therapy should be always cover staph aureus using penicillin-resistant penicillins, vancomycins, and daptomycin, often with gentamicin, and antifungals are added to select people who inject drugs. And a 2 weeks oxacillin or cloxacillin monotherapy without gentamicin is effective for MSSN, sensitive methicillin sensitive staph aureus, if the criteria was met. Otherwise, you have to go with MRSA coverage. In selective patients with PWID and uncomplicated MMSAIE, so we have to go with oral ciprofloxacin or rifampicin, standard 4 to 6 week therapy for IE. This is we already discussed. Coming to the what are the interventions which recently highlighted was tricuspid valve repair should be considered instead of tricuspid valve replacement whenever possible, which is a class 2A recommendation. Any large residual tricuspid vegetation more than 20 mm after recurrent septic emboli has a class 1 indication for surgery. Persistent vegetation with respiratory insufficiency is a class 1, and right ventricular dysfunction secondary to acute and severe tricuspid regurgitation, non-responsive diuretic is a class 1 indication. And debulking of right atrial septic masses or aspiration by using some selective aspiration catheters in patients with high risk for surgery, you can use angiovac for these cases, but the success rate will be little bit low. Coming to the infective endocarditis during pregnancy. So in pregnancy, IE is rare, around 1 in 1 lakh population, but carries high maternity and fetal mortality with preterm birth and over half the cases. Recurrent infections occur in 27% postpartum. High risk group include women with CHD, RHD, and structural heart disease, and prosthetic heart valves, and people who are injecting drugs. Suspect IE in any pregnant women, unexplained fever, tachycardia, new murmurs, or septic emboli signs. Prompt diagnosis and treatment planning according to patient will critical to improving the paternal and fetal outcomes. And cardiac surgery under CPB through rescue fetus should not be delayed if it is urgently indicated. Early intervention is the key, especially in cases with heart failure or embolic complications. So infective endocarditis in immunocompromised patients. So there are 3 types of immunocompromised. The first one is solid organ transplant and people living with HIV and patient with neutropenia. And solid organ transplant patient, staph aureus is a leading organism. The most commonly it was involved in 72% of the cases of kidney transplant and 17% liver and 8% pancreas transplants. And outcomes will be similar to non-SOT patients only. And infective endocarditis, particularly in HIV, in CHD and CID and hemodialysis patients, the staph aureus remains the most common pathogen. Cons rate was dropped while streptococcus, gram-negative bacilli, enterococcus, and fungal are increased. Outcomes have improved markedly. Surgical treatment indications are same as non-HIV patient. And IE is rare in neutropenic patients, but difficult to diagnose due to apical presentations of delayed immune response. But caution should be needed with agents like cloxacillin and ceftriaxone, which may exacerbate neutropenia in these cases. Non-bacterial marantic thrombotic endocarditis, which was 1.1 to 1.6 in cases of autopsy diagnosis, typically in patients with hypercoagulable states such as SLE, antiphospholipid syndrome, and malignancy, which was a marantic endocarditis, and DIC and chronic inflammatory diseases. In a registry which was published recently, there was a 41% of non-bacterial endocarditis have cancer, notably lung and breast and pancreatic, and 33% SLE and 36% have antiphospholipid syndrome. The most common presentation was stroke in these cases. Any case with atypical presentation with stroke and any vegetation which will be seen and blood culture was negative, you have to suspect for non-bacterial marantic thrombotic, you have to work accordingly. The mitral valve is most frequently involved, which was 62%, and the TT has limited sensitivity, while 3D TOE offers better characterization of tissue characterization. And differentiation from IE, lumbal excretion, fibroelastomas are essential. Libman-sac vegetation have distinct echocardiographic features, typically lack wall perforation, and which was on both sides of the wall. And management should be like anticoagulation, and surgery is reserved for patients with severe valvular dysfunction and large vegetation, though the role remains controversial. IE in patients with malignancy, IE occurs in 11 to 18% of the patients with active or prior malignancy, and these are the typically in older and more nosocomial infections. Procedure triggers like IV catheters, endoscopy, and GU interventions. Outcomes were has high mortality definitely, and similar to despite similar surgical indications. Independent predictors of mortality include elevated creatinine and congestive heart failure and lack of indicated surgery. Management should be surgically. Coming to the last side, these are the key evidence gap in infective endocarditis. The first gaps will be in diagnostic and therapeutic uncertainties. Still, they include FDG PET and CT in native endocarditis, intracardiac echo and prosthetic endocarditis, and brain imaging for emboli. But there is a limited limited data on these molecular tools, and antimicrobial therapy lacks a robust RCT for many regimens. Uncertainties persist around optimal agents for resistant organisms like Enterococcus faecalis and vancomycin resistant enterococci. And duration of therapy and oral treatment regimens and we sometimes we don't know that how many days we have to give the oral treatment, and there is no such indications for recurrence or relapse cases. How many days we have to continue that antibiotics. And the procedural post-procedure gaps was limited data access on vegetation or extraction systems for particularly right-sided IE and mechanical thrombectomy for embolic strokes and splenectomy timing in IE and splenic abscess. And some sex disparities in IE incidence outcomes and surgical referral require further investigation and targeted solutions. Thank you.